चल लाइव कर दो।
Yeah.
जस्ट सर 30 सेकंड।
Good evening, everyone. I welcome all of you to yet another session of Innovations in Hematology webinar series. Innovations in Genomics webinar series has been going on for the last 1 year, spearheaded by Dr. Srinidhi Nathani, who heads the Department of Molecular Hematology and Genomics at Fortis Memorial Research Institute. This evening, we'll be discussing about the AML classification current framework and what's new in classifying AMLs and the genomic landscape of AMLs. Over the past 1.5 years, we have been fortunate to have Dr. Srinidhi in our team, where we have been having a rapid NGS program with the fastest 72-hour turnaround time in the country. It is routine for us to do an NGS at baseline, and over the last year and a half, doing an NGS MRD in our post-transplant patients has significantly changed our decisions regarding maintenance and immunosuppression tapering in a post-transplant setting. Today we have Professor Nicolas Dupleix with us, who is an associate professor in the Department of Hematology, Molecular Biology at the University of Lille, France. Professor Nicolas is a leading physician scientist specializing in AML, MDS, and molecular prognostication. He has published influential research on the genomic landscape and classification of hematological malignancies, which are well cited. Actively involved in translational research, he focuses on MRD monitoring and genetic risk stratification in AML. His innovative work aims to refine therapeutic strategies and improve patient outcomes in high-risk myeloid neoplasms. He is a member of the Scientific Council, University of Lille, as well as member of various other academic bodies. He is a vice president of the Scientific Steering Committee of the Alpha Group and a member of the Expert Committee, Immunology and Hematopoiesis at the French Cancer League. We would be very excited to hear Dr. Nicolas speak about his perspective on NGS in myeloid neoplasms, as well as the genomic landscape. And please feel free to share any questions in the chat box, which we can take up with Professor Nicolas during the question and answer session. This is our team at Fortis Institute of Blood Disorders. Thanks to this wonderful team, we are able to perform more than 250 bone marrow transplants every year. And we have an extensive genomic program where we have an in-house next generation sequencing and the hematopathology lab, which does a flow-based and other tests. So we'll be discussing more about our approach during the question and answer session. I'll stop here and I'll hand over to Dr. Nicolas for his lecture.
You can see my screen.
Yeah, your screen is visible in full screen.
So good evening, everyone. First, many thanks for the proposal to talk to you about HML classifications. We'll discuss today how classifications have evolved over time, how genomic discoveries have reshaped our understanding of the disease, and how we can use it in clinical practice. So first of all, AML is a relatively rare disease, but its incidence increases with age, with a median age at diagnosis of 70 years old. Survival rates vary from 70% at 5 years in children compared to only 20 or even less in the elderly. And it is important to say that most of our current knowledge comes from studies conducted in the context of young adults treated with intensive chemotherapy, which for decades remains the only available therapeutic option. It has been 50 years since we classify AML. The first milestone was the discovery of recurrent translocation, with the first one discovered by Janet Schwole in 1973. And it's funny to remember that this discovery, the first recurrent translocation in AML, was subjected to the New England Journal of Medicine, and it was rejected by the editor-in-chief because at this time genetics was not very important in cancer. So it was published in a French journal of cytogenetics because the editor-in-chief was a cytogeneticist, and he knew that cytogenetics and genetics was important for cancer. The other milestone was the transition to the molecular level with the discovery in the late 90s of recurrent mutations, especially in cytogenetically normal AML. The first genome in 2008, and after that, the publication of 200 additional cases by the Cancer Genome Atlas in 2013. So those discoveries have been accompanied by the development of high-male classification. You can see at the bottom, and successive updates with increase of knowledge. A more schematic way to represent the evolution of classification is here, and schematically, all those discoveries have transformed AML from a morphologically defined disease into a genetically stratified malignancy. And this has been demonstrating that AML is not a single disease, but a constellation of distinct and heterogeneous entities defined by gene fusion, by chromosomal aberration, by mutations, with diagnostic and prognosis implication. Just you can see here the WHO classification, which has progressively incorporated these advances in its classification, making more and more precise and also for us more and more complex. And the 2022 update is nearly based on genetics. It removes the clinical history of MDS or therapy from the definition, although it continues to report them as diagnostic qualifiers. And only remaining cases are not classified by genetics are classified with morphology, but nearly all cases are now classified with genetics in the last update. So why do we classify leukemias? In clinical practice, it provides us a way to compare our patients with other patients sharing the same disease. So we can predict disease course by comparison with other patients. We can define the benefit risk of transplantation. We can choose the right treatment strategy depending on biological targets or vulnerabilities of leukemic cells, and we can plan residual disease monitoring. And for research, it's also very important because it allows us to compare patient populations and draw conclusions between studies. So since AML is very heterogeneous, it provides a way to quantify this heterogeneity between studies. We mainly use two kinds of classification in practice. Diagnostic classification, such as WHO or ICC. They are based primarily on biology and genetics. They identify distinct identities of AML sharing the same biology, maybe the same therapeutic vulnerabilities. And with current strategy today, these entities may or may not have prognostic value. Prognostic classifications, such as ELN, take genetics and therapy into account. And in this sense, they can only be used in specific therapeutic situations and will evolve when new treatments become available. And during this presentation, I will navigate between the two types of classifications, which because they overlaps, of course. A major step of the last update of IML classification is probably the incorporation of genetics to define IML ontogeny. Traditionally, we divided IML into de novo, secondary, therapy-related, based on clinical history, but studies, especially the landmark paper by Coleman, Lindsley, and colleagues, have demonstrated that mutations are more accurate indicators of disease ontogeny than a patient history. Come back to this paper briefly. The authors studied cohort of clinically defined AML, de novo, secondary, therapy-related, and they demonstrated that among de novo AML, a set of 8 genes, I6L1, ZH2, BCOR, STAC2, SF3B1, SRSF2, UZIF1, and ZRSR2, defined a group of AML that is prognostically similar to clinically defined secondary AML. They call them secondary-like AML. We also use myelodysplasia-related AML. And interestingly, those genes can be, to a biological point of view, those genes can be classified by functional categories. And doing this, we see that the four first genes are involved in RNA splicing, SRSF2, ZRSF2, SF3B1, and UZIF1. And the other are involved in chromatin modification, two pathways that are frequently involved in myelodysplasia. That is to say that these genes are surrogate of prior MDS, but it is likely that also genes less frequently mutated could have the same value. However, the study was not powerful enough to identify rarer mutations. These studies and others justify to consider patients with secondary-like mutation in the poor prognostic subgroup in the ELN classification in patients treated with intensive chemotherapy. However, you can see on the right that these patients significantly have a better outcomes than patients with other adverse risk genotypes, especially TP53 mutated AML or complex karyotype. So probably the definition of secondary-like ML is not perfect, and some studies have tried to improve this definition. In this one from colleagues of New York, the authors extended the list of secondary-like genes, and also they showed that the poor prognostic was more evident in patients harboring at least 2 mutations in this list. The opposite, we have NPM1 mutation, which are a feature of de novo AML. The NPM1 gene encodes the nucleophosphine, which is implicated in several pathways, including mRNA transport, chromatin modeling, apoptosis, genome stability. An NPM1 mutation are found in about 40% of de novo AML, and they led to the disruption of the C-terminal part of the protein with the replacement of a nucleolar nucleolar localization signal by a nucleolar export signal, and the subsequent mislocalization of the protein in the cytoplasm. NPM1 mutation define a distinct AML entity in a diagnostic subgroup in the WHO ICC classification, but it's also the only the sole AML entity for which additional aberrations are considered to classify NPM1 mutated AML in the 3 prognostic groups of the ELN classification, the prognostic classification. The most frequent is the co-occurrence of FLT3-ITD. You know that in 40% of cases, FLT3-ITD worsens the prognosis, justifying the classification of NPM1 plus FLT3-ITD in the intermediate prognostic subgroup in the ELN classification. although it is exceptional, some patients with NPM1 mutations have a complex karyotype, and those patients have a very poor prognosis, similar to complex karyotype only without NPM1 mutation. So those patients are classified in the adverse subgroup. The impact of secondary type mutation is more debated in NPM1 mutated AML. Some studies have shown they confer a poor prognosis to NPM1 mutated AML. Others showed they have no impact. And other again showed it depends, which is probably true. The answer likely include other parameters such as age, the number of secondary type mutation, maybe not all secondary type genes are equal, so it remains debated. And finally, we know, especially in NPM1 AML, that mutations can have additive effect. It defines what we call mutational synergy, when the additive effect of mutations together is higher than you can expect. In this AML subtype, it is known that cases harboring NPM1 plus FLT3 ITD plus DNMT3A have a particularly poor prognosis, but this subgroup is not included in the HLN classification. So to resume NPM1 AML, initial risk assignment may change during the treatment course based on the result from analysis of MRD, but initial risk is defined by the co-occurrence of FLT3 ITD. If you are FLT3 ITD, patients are in the intermediate risk subgroup. The poor prognosis of the adverse karyotypes prevails over NPM1 mutation in this subtype. And the co-occurrence of myelodysplasia-related mutation should not modify risk assignment because we don't know really the answer of to this question. Sorry. Another anomaly I wanted to talk about is CBP alpha mutation. CBP alpha is a myeloid transcription factor. CBP alpha mutations are found in about 5 to 7% of de novo AML in young adults. Typically, both alleles are affected, one N-terminal mutation and one C-terminal mutation. Usually, the C-terminal mutation is usually in frame and occurs in the DNA binding domain called the basic leucine zipper. Initially, it was described that CBP alpha double mutation or biallelic mutation were associated with a very good prognosis. And more recently, it was suggested that the good prognosis was found in all patients with in-frame mutation in the BASIP domain, even if there was only one mutation. It was found in adults and children, but because CBP alpha mutations are uncommon, it was shown in only small cohorts. And unfortunately for all of us, national experts who established different classifications, the WHO, the ICC, disagree about the definition of the entity of CBP alpha mutated AML, especially the distinction between a biallelic mutation, monoallelic mutation, and BASIP domain mutation. In a large effort, the Study Alliance Leukemia conducted a large retrospective study enrolling more than 1,000 CBP alpha mutated patients from 6 European cooperative groups. In this work, they classified CBP alpha mutation according to several factors. First, the number of mutations, the site of the mutation, BASIP or not BASIP, the type of mutation, and thus they established 8 groups. So this is the definition of the 8 groups. I show here the proportion of patients in each group. The most common are double mutated with at least one in-frame BASIP. which is known to be favorable, and all classifications are agree with that. And the other group is single mutated CUBP alpha mutation without BASIP mutation, which has no impact in current practice, and everyone is agree with that. I show here the definition of CUBP alpha mutated AML in the WHO classification. So in this group, you have in-frame BASIP mutation or biallelic mutation, even if there is no BASIP mutation. Now I show you the definition of the ICC and also the ELN classification. This is quite different, but it concerns, of course, it concerns small subgroups. And it is a reminder here that ELN 2022 considers a favorable prognosis only in case with CUBP alpha in-frame BASIP mutation. Here is a prognosis. So double mutated are solid lines, single mutated are dotted lines. Then colors show the type of BASIP mutations. In details, patients in the first group 1, so it is a double mutated CUBP alpha with at least one BASIP mutation. They show the better prognosis. And the group 5, single mutated CUBP alpha mutation with BASIP domain, in-frame BASIP domain, was less favorable than the first group, but they were still better than the other groups. So here, the definition of the ELN. Additionally, they showed that only the studied the ELN classification according to CUBP alpha statutes, and they showed that only BASIP indel mutation have a prognostic impact, irrespective of the additional mutation. If you have one mutation CUBP alpha BASIP indel with secondary type mutation, it has no impact, but other ELN factors kept their impact in other subgroup. So in this paper, they proposed a new definition here in green. You should consider only patients with CUBP alpha mutation in the BASIP domain that are in frame to have a good prognostic. Another way to resume in brief, simple message: those mutations at the top are cool, and those mutations at the bottom are not. So remember, most of studies explored intensive chemotherapy, and mainly in young adults. Thus, current prognostic classification have been developed based on those studies. It is not so surprising that these classifications are less efficient in other populations. I am lucky enough to work in a laboratory where we centralize the biology of pediatric and adult trials, and we produce data in these populations. You can see here that the ELN classification is particularly not relevant in pediatrics AML on the left. And here it's a figure with genomic data from various French trials together. It highlights that AML genetic subtypes are age-related, with distinct profiles in younger versus older adults, especially adverse subtypes such as secondary type AML in dark blue, or TP53 mutated AML are nearly absent in children, while they account for 2/3 of patients after 60 years old. NPM1 mutation are also less common in children than in young adults, but children display more recurrent translocations. These graphs also highlight some rare subgroups that are more frequent in older children or very young adults. here. And because of the design of our trials from 0 to 18 years old or from 18 to 60 years old, these subgroups are usually underrepresented because they are split between the different trials. That is probably a reason why they are not included in the current classification. I highlighted two subgroups, very interesting subgroups sharing the same characteristic, NUP98 and UBTF tandem duplication. Briefly, NUP98 is a master gene that can be fused to several partners, but the most frequent is NSD1. Flat3 ITD and WT1 mutation are the most frequent commutation in these subgroups. And those patients with NUP98 rearranged AML have a very poor prognosis. It is well recognized in children, and it tends to be recognized in adults, but only in small cohorts in the literature. UBTF tandem duplications were more recently described. Although hundreds of AML genomes have been done, UBTF mutations were not reported because there are large duplications of the genes that were very difficult to identify with standard bioinformatics pipelines. UBTF encodes the proteins that regulates ribosomal RNA transcription and ribosome biogenesis. They were first described in children, but they are also found in young adults. As described for NUP98 AML, the most frequent commutation are Flat3 ITD and WT1. Morphology is usually characteristics with dystrophic erythroblast and megakaryocytes. They display, as NUP98, a poor prognosis with a bad response to chemotherapy. And why it is important to consider these alteration as distinct entities because of their specific biology. Interestingly, both subtypes are known to overexpress MES1 and OX genes, which are considered to be surrogates of the sensitivity to menin inhibitors, which is a new therapeutic class. And there is some case reports which show that some patients with those abnormalities can respond to these treatments. So now back to older adults. As previously discussed, older adults are characterized by the huge proportion of poor prognostic markers, making LN less efficient to stratify patients. In 2021, we described a classifier of 7 genes to stratify older patients into go-go patients, those for whom you should do intensive chemotherapy if you can. Slow-go patients for whom alternative, especially azacitidine venetoclax or other, should be discussed. Of course, other colleagues of the groups have proposed other classification, but that is only to say that some markers, for example, RAS mutation, may be relevant in some population and not in other population. Let's go to the second part of the presentation. Intensive chemotherapy is no longer the only therapeutic option in our patients. And since the vast majority of patients are older adults, the question is the ELN classification still relevant in my patients receiving less intensive therapy? And you know the answer is no. Not the 2022 classification. The most common alternative is, of course, the combination of azacitidine and venetoclax. You all know the results of the VIAL-A trial for older patients ineligible to intensive chemotherapy. In this cohort, ALN 2017 and 2022 did not adequately stratify overall survival for patients with AML treated with ASA venetoclax. And to understand this, we have to come back to the mechanism of action to venetoclax. Venetoclax is a BCL2 inhibitor that will finally promote apoptosis. BCL2 belongs to a family composed of pro-apoptotic genes, BAC, and anti-apoptotic proteins, BCL2, MCL1, BCLXL. Several mechanisms of resistance have been described, and we'll just discuss two of them. TP53 is a master regulator of apoptosis in cells. As a central regulator of DNA damage response and apoptosis, TP53 mediates cell cycle arrest and activation of pro-apoptotic genes following a genotoxic stress. In TP53 mutated AML, the addition of venetoclax to chemotherapy or azacitidine has not resulted in durable improvements of outcome because TP53 mutated cells exhibit reduced dependence on BCL2 and then they have shown to require an increased threshold for BAC to activate apoptosis. The other major determinant is the emergence or clonal selection of FLT3 ITD mutation and or other kinase activating mutations, including other FLT3 mutation and RAS pathway mutations. These mutations are known to induce higher expression of MCL1 or BCLXL, which may contribute to venetoclax resistance. Interestingly, it is suggests that not all RAS mutations are equal, with KRAS and PTPN11 leading to higher upregulation of MCL1 than NRAS mutation, for example. So by chance, investigators of the VLA study are also those involved in ELN updates. So they rapidly proposed a new classification adapted to patients who received ASA venetoclax. It is a genetic-only classification with 4 genes, the tumor suppressor TP53, and 3 signaling gene, FLT3, only FLT3 ITD, NRAS, and KRAS. So you can see TP53 are in the lower benefit group, and FLT3 ITD or NRAS or RAS mutation are in the intermediate benefit subgroup. And all other patients are in the higher benefit group. Since previous studies have shown that NPM1 and IDH1 and IDH2 mutation were more sensitive to treatment with venetoclax-based regimens, they provided the analysis by subgroups. And while these mutations are still associated with a favorable outcome, the benefit is mainly restricted to patients without signaling mutations, such as FLT3 ITD, NRAS, or KRAS. And also TP53 mutation are usually exclusive to these subgroups. So the 4-gene prognostic model remains predictive in NPM1 and IDH1 to mutated AML. A pitfall recognized by the authors is that not all mutation could be assessed in the trial, especially other signaling mutations. And since everything moves very quickly today, a revision of the ELN 2024 classification has already been proposed. In this revision, PTPN11 is introduced, and KRAS is downgraded to the poor prognostic subgroup. This may be due to the greater upregulation of MCL1 by PTPN11 and KRAS compared to NRAS. Although it's not published yet, we submitted an abstract to the next ASH meeting showing a better performance in our data of this revision. So this led to the design of the new ELN 2024 prognostic classification. This classification is established for all available therapies classified as less intensive. mainly for ASA plus venetoclax, you will therefore find the 4-gene classifier here. A reminder is that favorable outcome for NPM1 and IDH2 mutations is restricted to patients without signaling or without TP53 mutations. This also highlights the specificity of IDH1 mutations, since the combination of azacitidine plus ivosidenib has been shown to be a better option in these patients. Finally, this classification introduces DDX41 mutations. DDX41 mutations have been widely studied worldwide, and there is increasing evidence that DDX41 mutation, usually germline, represent a distinct entity of AML and also MDS. They are found in about 5 to 8% of AML or MDS patients, older patients, and they represent a continuum between usually between AML with low blast count and MDS with excess blast. Those patients are usually leukopenic and display hypocellular bone marrow. Median age at diagnosis is 65 years old and predominantly in males, and we don't know why the risk is lower in females. The DX41 mutated MDS or AML are characterized by a good response to all available therapies, including intensive or less intensive chemotherapy. They have a more favorable outcomes than wild-type patient when treated with azacitidine alone or in combination with venetoclax. And those patients are usually wiped out for TP53 or signaling mutations. There is one final important note in this table. It is acknowledged that the data concerning other mutation or other cytogenetics, for example, are insufficient to draw a conclusion. Therefore, the classification may change in the future. It will probably change in the future with new markers. So to conclude, AML classification has evolved dramatically over the last 50 years. They have positioned cytogenetics and molecular biology as a surrogate, integrating most of the data useful for treatment selection, because genetics is known to be age-related, to surpass clinical history, to drive clinical or morphological representation, and to predict treatment response or therapeutic targets. The challenge is, of course, to harmonize this classification, and we must also acknowledge their limitations. AML is a paradigm of genetic diversity, but this classification focus only on the most frequent genomic alterations. With on-off system, you have the mutation, you do not have the mutation. Data about less frequent alterations are lacking. They ignore the cooperation, the mutational synergy, the clonal interference between mutation, except for maybe for NPM1 and FLT3-ITD, which is a synergy. So finally, they may be imperfect surrogate, and I'm also thinking about the definition of the secondary like AML. Probably it's not perfect, and of course those classifications are mainly genetic. They are nearly genetic only, but we know, especially with new treatments, that morphology, phenotype are relevant in some context, especially with venetoclax and the monocytic differentiation. As novel therapies will emerge, ongoing refinement of prognostic model will be critical to optimally guide personalized treatment strategy across the AML treatment. And it will be my last sentence. And I acknowledge all my colleagues and team involved every day in the French molecular biology of patients with AML. And thank you for your attention, and I am available for questions.
Thank you, Professor Nicolas, for that wonderful presentation. More than 150 delegates have joined in from 6 different countries, truly diverse audience, and we have received many questions through the talk from all of them. So before we go on to the question and answer session and the questions we have received, a couple of doubts that I had as a clinician. You mentioned the importance of co-occurring mutations with NPM1 in that wonderful algorithm, how the co-mutation status affects the prognosis of NPM1 mutated patients. So do you think when we monitor these patients, apart from the standard PCR, which is recommended by ELN, we should be doing an NGS MRD to monitor these co-occurring mutations as well?
Yes, I think, of course, NPM1 the monitoring of NPM1 mutation is very important. Is very useful. It has been shown to be a good marker to stratify patients between those who required stem cell transplantation and those who do not require transplantation. But I think now we have the technologies to and also the treatments to monitor differently those patients. Especially here we now monitor FLT3 ITD mutations. When those mutations are still positive, there are patients with worse prognosis, and which is interesting today is that you can add FLT3 inhibitors and in those patients with FLT3 ITD positive MRD. I think it's more debated for other genes, but it is now you can find some data in recent papers that other mutations, such as of course the NMT3A, but WT1 mutations are also very important in to demonstrate the resistance of some cells, and those mutations can also emerge. So it's not really MRD because it's new mutations, but those mutations can emerge in patients with complete remissions and incomplete remission, and usually those cells are resistant to intensive to standard chemotherapy. So when patient will have a morphological relapse. So those technologies, MRD, are I think are useful because we have now the opportunity to treat molecular relapse. So I think you have to now to add several techniques and follow and monitor several markers in one AML patient, because you will have several different information, and you can it's actionable for us. You can add a specific therapy.
So we have had situations where patients had NPM1 and IDH1 at baseline. With treatment, the NPM1 mutation goes away, but the IDH lingers on 0.1, 0.2, small percentage of IDH1. So in such situations, do you think persistence of IDH1 mutation with disappearance of NPM1, is there a prognostic significance to this?
It's difficult to say because it's really frequent to have a persistent of IDH mutation after incomplete remission, and sometimes some patients will never relapse. So you can have a very large clone, IDH positive clone, with complete blood count totally normal. But we have in our experience some patients who totally cleared their NPM1 mutation, but who evolved in a few years with MDS, and sometimes with AML, with long-term relapse, not really a relapse, it's usually a new AML, but on IDH clonal hematopoiesis. We have a few patients who had a new AML on clonal hematopoiesis 8 or 10 years after the complete remission. And those patients are usually not captured in the clinical trials because follow-up usually is stopped before. So we lack some studies with very long follow-up. And I don't know what we should do, but we have now some treatment to target IDH. So I think studies should be done.
So that is exactly what we were debating in our group. Should these patients be given an ivosidenib maintenance if there is persistence of IDH1 mutation? But like you rightly said, I think the answer is not very clear at this point.
It's not very clear. And in practice, I think we should follow those patients with NGS, with the aim to detect emergence of new clones, which could be a surrogate of a new AML or MDS evolution. So the NGS, I think, will help us on this question. Yes.
With the new WHO and ICC classifications and important genomic criteria being coming in, what do you think is a main deterrent for clinicians to use these classifications in their daily practice?
I think I experience it is difficult in daily practice to understand all the details of the classification, the impact of co-mutation, the type of mutation for CBP alpha. It's very difficult. So I think it's important to discuss with the molecular lab to classify those patients, because the consequences are very important for CBP alpha. If you don't class the mutation in the good group, you have transplantation in one situation, or you do not transplantation. So it's very important. But I think we have to train to use those classification. Several groups in the worldwide have proposed more and more complex classification with deep learning or with other parameters, with morphology, with those classifications, those systems are usually better. They have better performance, but nobody use it because it's too difficult for our daily practice. So probably we have to train to use it and to simplify, because we have to understand how those tools work and how they will predict our prognosis for our patients.
Absolutely. I think as clinicians also, it's very confusing when we have so many classifications. I think it's really high time we have a unified classification, which is relatively easy to follow in a clinical practice. Moving ahead, with different definitions for MDS and AML in terms of genetic lesions other than the blast percentage, do you think we are moving towards a more continuum based model rather than a categorical classification when it comes to AML and MDS?
Yes, this point is already recognized by WHO and ICC for recurrent translocation and NPM1 mutation. They are lower the blast cutoff or even disappear the blast cutoff. I think it's clear for de novo AML. The blast cutoff is not really relevant. I'm not sure for secondary like AML, myelodysplasia related AML, or even TP53 AML. we have some literature which is discordant about this point, about the blast count in TP53 or myelodysplasia related AML. But probably when we have new therapies, you have new strategies, and of course it's not relevant to reserve some therapy to some patient because of a blast cutoff. So I think the philosophy of those classification, if if to consider the continuum, because you have the choice to consider your patient MDS or AML according to the classification you choose, and you can give as a treatment of your choice. I think it's important to have some clinical trials to address those questions. We have MDS trials, AML trials, and probably some trials with subgroups with the continuum of diseases would be important to draw a definitive conclusion.
Absolutely. You have done significant work on MRD in AML. So do you think MRD can become a formal component of future AML classifications and not just a prognostic tool?
Yes, so it's a little incorporated for NPM1. It is in the LN22 MRD will classify NPM1 mutated AML as favorable, intermediate, or adverse according to MRD. And I think it's also an answer to the first question. Maybe we can do, you can put more and more markers, biological markers in the classification, more and more entities. But some of them will be you can capture the poor prognosis of some abnormalities with MRD. So I think it could simplify the problem because poor prognostic AML will have MRD positivity, and good prognosis will have MRD negativity. So I think we'll have to, yes, reconsider classification over time with MRD, especially with new therapeutics, because now we can act on molecular relapse. So it's probably the most important change in the next years. Yes, to treat according to MRD.
And continuing with that, what do you think is the best way to monitor MRD? With an NGS MRD being available, how do you place flow MRD in your practice? Do you think it is still relevant, or NGS MRD being more sensitive can do the trick in all patients? Do you think we should still do flow MRD for all patients when we have a standardized NGS MRD?
It's difficult to answer because it's not treated the same. It's not the same technology, but it's you don't look the same thing with those technologies. So in practice, we do both. Also, it's more expensive, but we do both. I think NGS, you have the advantage to maybe now have actionable targets. If you can follow flat-free ITD, ID watch, I don't know. You can act on clonal hierarchy, but with flow, you have some informations. You can follow leukemic stem cells. In practice, we follow leukemic stem cell plus leukemia aberrant immunophenotype. And both informations are important because with NGS you will have also clonal hematopoiesis, so lots of data that are not relevant. So I think unfortunately we should use both.
In TP53 mutated AML patients, we see a wide variety of responses when it comes to treatment. Some of them do very well in spite of having high variant allele frequency TP53 mutations, and some of them do poorly even if the VAF is low. So beyond VAF, do you think the type of TP53 mutation matters when it comes to overall prognosis?
It's an important question and difficult to answer because there are lots of studies with different cutoffs for blasts, for example, with different technologies. And maybe TP53 is not the perfect surrogate. Maybe what is really important, I think, it's my opinion, what is really important is biallelic alterations. And of course, in the majority of cases, you have one deletion and one mutation or two mutations. But now here in France, we perform for some patient whole genome, whole exome, and RNA sequencing diagnosis. And you can find some patients with only one mutation or no mutations and a complex serotype, for example. And we will find other aberration in the TP53 pathway or in TP53 a promoter of fusion of TP53. You have several mechanisms that could explain biallelic alteration of TP53, and you can find with our NGS strategy, current NGS strategies. So and in the published studies, those cases are not captured. And we could not explain that by patients with a low TP53 VAF with a very poor prognosis. Maybe it could be explained by another alteration you didn't find. In my experience, there is no real difference with the type of mutations. There is a difference between single alteration and double alteration. We can see different biology when you use the RNA sequencing. For example, you can have some patient with no TP53 expression and some patient with expression of a TP53 mutated protein RNA. So maybe there is biological different pathway, but in practice, of course, prognosis is really poor. So it's difficult to find subgroups with some response to therapy.
Your research has highlighted key genomic drivers in AML. Which genetic alterations do you think are currently underestimated in terms of clinical significance?
I talked about them in this presentation. I think some very important abnormalities are NUP98 and UBTF. It seems rare, but it's about 3% or 4% of patients in young adults, very young adults, or in all children. Those young adults and children have usually a good prognosis, but UBTF and NUP98 is a very poor prognostic marker in this population, usually refractory AML, relapse, resistant relapse. So I think those abnormalities are very important to detect, especially because now we have strategy. They are usually FLT3 ATD positive, and maybe we have menin inhibitors, so maybe combinations of therapy in the future for children, especially. And the other one, which is in the 2024 classification, is DDX41. DDX41 is very frequent. In fact, it is more frequent than CBP alpha mutations. It's more frequent than KMT2A translocation. And they have a specific response to therapy. So I think those mutations should be incorporated in the next classifications. And of course, I think some definitions are not really perfect, but they work. But the definition of myelodysplasia-related AML is not perfect. Maybe we should improve this definition with new genes, with new combination. But of course, it's more complicated to understand after that.
Absolutely. I think it's very important to have a NGS panel which covers all these mutations. And very often we see NGS reports which have done only a DNA sequencing, only the DNA based test is done. And in those tests, the fusions are missed. And when we repeat at our center, very often these important fusions do come up. So I think the validity of the NGS, the panel, including looking at fusions, is very, very important because, like you rightly mentioned, all these have very important therapeutic implications as well.
Yes, yes, and it's also very interesting for MRD monitoring. I don't know if you do that, but in my lab, we all genomic fusion are monitored by digital PCR. And for children, for example, you can follow 2/3 of patients with fusion, with a rare fusion or common fusion with specific design, and we perform stratification based on MRD, fusion-based MRD.
I'll take one question from the chat box. Young male with KRAS, PTPN11, and ASXL1 mutation. What is your choice of treatment? How would you go about it?
So in France, I'm a molecular biologist. I do not take care of patients, but uh, so it's a difficult answer for me, a difficult question for me.
So on
For
that
young
same
for young patients, I think I will do intensive chemotherapy in all when if it is possible in a young patient with transplantation.
So on that same note, the median age of AML patients in India is around 42 years, at least 1.5 decades younger than the European counterparts. And in young patients, we see more and more patients with myelodysplasia related mutations. So very often we wonder in our practice whether these patients would actually benefit from an intensive chemo or a low intensity chemo like azaven would be beneficial. So you mentioned in your talk how some elderly patients can possibly benefit from intensive chemotherapy. But here the problem we face is slightly different. We have young patients with myelodysplasia related mutations, TP53, very high VAF, biallelic TP53. So it is a constant debate in our team whether to really subject these patients to an intensive chemo versus going for a low intensity therapy.
Yeah, I understand. Yeah.
And moving forward, do you think the next AML classification will move towards a more functional pathway based categories rather than a gene based ones alone?
I hope, yes, but it will be difficult to integrate in clinical practice, I think. But it's always done in some groups. I think St. Jude Hospital, for example, proposed a classification based on RNA sequencing in children, of course, but and with that they define functional subgroups with different expression, and probably it's more relevant in children than in adults. So with RNA sequencing, you have some informations. I think probably we should incorporate some phenotypic data. Maybe monocytic differentiation is better than NRAS, KRAS mutation. But of course, it will be difficult to have studies forward enough to answer, because when you multiply the markers and the technology, you have multiple subgroups of little subgroups of patients, and it will be more and more difficult to find a specific impact. But I think we should move to that, especially with new therapy. It was not really important, in fact, when we have intensive chemotherapy, only because you can do intensive or you cannot do intensive chemotherapy. But now it's really important with the new therapeutic option.
Another question from the chat box. How often do you see IKZF1 mutation in AML and what is the prognostic significance?
IKZF1 mutations are very uncommon, maybe 2 or 3% of patients. There are usually you can find IKZF1 mutation in two kinds of AML. In CBP alpha mutation, you can have IKZF1 mutations, but they do not affect the prognosis. But the study is difficult because CBP alpha are very uncommon AML. And the most frequent situation is IKZF1 mutations in patients with myelodysplasia-related AML. So they have usually a poor prognosis, and icazidofone is associated also with a poor prognosis, but I don't know if it is really icazidofone or myelodysplasia-related mutation. But some interesting publication showed that IKZF1 mutation can, in some myelodysplasia-related patients, lead to OX and MES1 expression, like in NPM1 mutated AML, and maybe it's a surrogate of response to menin inhibitors or other therapy, but we have no data from clinical trial to answers. But it's an interesting mutations, I think, because it seems it changes the expression of some genes that are surrogate markers of treatment or response to treatments.
Moving on to the last couple of questions, artificial intelligence and machine learning have been shaping up things in various aspects of hematology. How do you see these tools contributing to future AML classification frameworks?
It's those tools are amazing. I think it's very interesting. It's very powerful. It will probably classify patients better than we can do today, but it's for the moment, I think it's too difficult to understand how it works, and so how we can be confident with those technology. We can do beautiful papers with artificial intelligences, but I, I, here in France, I think we are not really ready to use it to stratify our patients. It's wonderful to understand disease, maybe to discover specific subgroups, but after we'll have to identify surrogate marker to use it in clinical practice. But it's my opinion.
Absolutely. I think we totally agree with you. But the ability of artificial intelligence models to really pick up patterns is truly amazing. So, in our group where we do extensive transplants, very often we have used these models to try and look at predictors of renal dysfunction in transplant patients and better predictive models by which we can actually predict the post transplant outcomes. And these are truly unique with Dr. Srinidhi around. We have an artificial intelligence club at Fortis, and we try to see how best can we use AI to have predictive models, which are much better than what we have today. And we would be actually happy to collaborate with your team in this aspect.
Yeah, we use it. You can, in fact, we use it when we hesitate with a case. If we do or do not perform HSCT, a transplantation, it can provide a new argument to do a choice, but not in the front line for us.
Absolutely. And I think we have already crossed the time. Last question for the evening. More of a speculative one. What will be the biggest change that you anticipate in how we classify and treat AML in the next 5 years? With abundance of data, widespread NGS, more and more mutations coming into the picture, and with AI and machine learning in the background, do you think we are going to classify and treat AML a lot different in the next 5 years than what we are doing today?
Yeah, it's a great conclusion. I think we will have to move from a on-off system. You have or you not have the mutation. We probably will have to consider multiple markers to identify a specific biology. Specific yes, specific biology. Uh, I think the most important thing in the next years will be the incorporation of the new treatments. So we'll have new markers and to incorporate treatments with MRD. So we have to classify prognosis of patients with MRD and with new therapy available. Yes.
Absolutely. I think as clinicians, maybe a decade back, starting from treating most patients with 3+7 induction or maybe single agent AZA, this is what we used to do during our training. There were very few limited options, either treat with 3+7 induction or AZA, or add venetoclax in few patients who can really afford it. From that, we have come a long way in actually giving, identifying mutations and genomic inspired treatments. Various large multi-center trials like the Mylomatch trial, which is ongoing, would provide a lot of clarity on genomic inspired treatment in patients. And we are very, very fortunate as clinicians to have a robust molecular hematology team, which provides us reports very quickly so that we can make treatment decisions that serve our patients the best. With this, I thank you, Dr. Nicholas. It has been a pleasure interacting with you. Wonderful talk, followed by a great discussion. You have patiently answered all our questions. Thoroughly enjoyed it. Thank you so much for joining us this evening.
Thank you. Thank you very much.
And I thank the 150 plus delegates who have joined from across the world. Thank you for sparing your Friday evening and have a great weekend. We would catch up with the next webinar on the 12th of this month, where we would be having a discussion on diagnosis and optimal treatment of adult HLH. I thank one and all who has joined in, and thank you, Dr. Srinidhi, for organizing this wonderful talk. Hope to collaborate with you more in the future. And before we wind up, I would like to thank MCure for providing this platform for seamlessly conducting this webinar over the past couple of years. I thank everyone who has joined in. Have a great weekend. Thank you.